Let's go ahead and get started. So good afternoon and welcome everyone to Module 5 of Coming to the Table, a Pediatric Primary Care Healthy Weight Initiative for Children and Families. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event. This event is being recorded. This is our little disclaimer at the front end of Zoom. By joining this event, it automatically sends you to this recording. If you feel uncomfortable and do not want to be recorded today, we do ask that you kindly leave today's session. Again, today's session is being recorded. You have either joined by either physically calling in or using computer audio. Either option is completely okay. I always say that it's best to call in if you're in an area where Wi-Fi can be sometimes a little bit spotty and you'd like to hear all of our lovely content live. Of course, Zoom, you do have the ability to mute and unmute your line. You obviously have the ability to share your video as well. We do ask that you keep all lines muted during the session unless you're going to be contributing verbally. This is really just to avoid any sort of background noise interference. And again, you do have the ability to share your video. We may be coming in and out of the presentation mode and what I like to call is Brady Bunch mode. So we'd love to see your faces out there in our audience. Again, chat box is open, either located in the lower right-hand side of your computer screen, or you may have to take your cursor, toggle over to the top bar to drop that in or drop that down. Simply type your comments, questions, or concerns into this box at any time. We'd love to hear from you and can't wait to see what you have for us today. Friendly reminders that today's event is being recorded. We ask that you keep your audio line muted. This is really just to avoid any sort of background noise interference. Chat box is open and ready for all of your comments, questions, or concerns. At this time, I'm going to be turning over the presentation to our presenters today. The floor is yours.
All right, thank you so much. I always like the energy that Liz brings at the beginning of calls. You may ask, who is this today? My name is Sarah Price. I've been working behind the scenes with all of our wonderful facilitators and speakers. I am a community health nurse by training and by heart, and I work at NAC in the Clinical Affairs Division as the Director of Public Health Integration. And it's been such a joy to sit back and watch both my colleagues and also our wonderful health center and other presenters throughout the last 4 modules be able to just take it away and share all these wonderful things. So I'm your MC today. You will hear very little from me because we have a wonderfully full agenda for you today, full of people who know much more about this and live this and breathe this than I do. As we're getting everything set up, we're going to actually start with a meaningful work moment. We've been doing this throughout each of our modules so that everybody can really just take a break and center themselves and be ready for our time together today. So our meaningful work moment for today is a series of 2 questions that we want everybody to be able to share in the chat. So the first question is, what matters most in your work in this space? Or what keeps you motivated and coming back to this work? So what matters most and what keeps you motivated and coming back to this work? So go ahead and throw that in the chat for us. And I'll read some aloud as they come in. Relationships, helping people achieve better health. That's very motivating. Who else? What matters most? What keeps you motivated? Patience and making a difference. Someone says connections with patients and team members and the impact we have to be able to help people. Children's confidence increasing. I love it. Children's futures and all children's futures. Excellent. Excellent. Equitable supports and resources. Wonderful. Keep that frame in mind. We absolutely, want to keep this chat train going. But I also want to get to our content. So please, feel free as things come to mind, what matters most, throw that in the chat. And anytime during our presentations, if you have a thought or a question or a comment, we're going to have Q&A at the very end. We want to actually get through everybody, but feel free to throw that in there and we'll be addressing any comments or questions that you have Perfect. So yeah, keep those up. Next, we'll go over our agenda quickly. First, we have a wonderful CDC presentation by Renee Porter, who is our CDC representative today. So we'll hear from her kind of laying the foundation around the science and the why behind why we're doing this. We'll then have a wonderful speaker from GI Carmichael Family Health Center, one from Heal, Mississippi, another one from BORINQUEN Health Center, another one from El Rio, in Arizona, and then Q&A. So we are full. It is a full feast today. We're so excited to get you there. Without further ado, let's go ahead, and I'm going to turn it over to Renee Porter, who is our CDC representative today. Renee, the floor is yours.
Can you hear me, Sarah?
We can.
Awesome. Okay. Thank you all so much for being here today. I am a contractor that supports the CDC work around NAC and the work. I've actually supported the work with COMMIT, which is the implementation of healthy weight programs for the past 3 years. All of my colleagues are out on vacation, and so I luckily get to be on this call today, which is so exciting. I don't want to take a ton of time because I know that the real world implementation, which are the following presenters, are really important. This presentation is just my opinions and not the views or official views of CDC. I will say that our work comes out of the Division of Nutrition, Physical Activity, and Obesity, and we are in the National Center for Chronic Disease Prevention and Health Promotion. Next slide, please. So briefly, I want to overview sort of why these programs are the way they are, right? All of this is grounded in significant evidence. And so when we talk about sort of healthy weight programs for families, it is really grounded in this evidence. And we talk about like what is a US preventative healthcare or task force recommendation. So what the USPSTF does about every 5 years is review evidence base for treatment and screening for children with obesity. And in 2010, and then again in 2017, they sort of came up with this idea that clinicians should screen children 6 and above using BMI and offer refer to a family healthy weight program. This is based on over 60 randomized controlled trials that show that these interventions, these intensive healthy weight interventions, actually reduce weight, reduce excess weight, and improve sort of the overall lives of children. Next slide, please. So they sort of grounded this idea of these intensive programs on sort of core components. And so when they looked at over 60 randomized controlled trials, they found that they all sort of had the same kind of components, which are they were all similar in their content. They all addressed nutrition, physical activity using counseling mechanisms. They focused on behavior modification. They were family-centered, meaning it wasn't just directed at the child. And they focused on skills training. They also feel like it's really important to address context, that children do not live in a silo of this intervention, but that social determinants of health are really important, not only to screen for, but also to provide the assets that are necessary. That we should all be aware of our bias and stigma when we're entering sort of this world with families and really come at it with a patient-centered focus. The other really important component of these healthy weight programs is that the higher the dose was better. So what that means is these interventions all offer greater than 26 hours over the course of 2 to 12 months. Now, that does not mean that every family member attends every session, but the offering, sort of all of those components within this. Booster doses and maintenance are really important. And why this is important is really to understand the chronic nature of obesity, that when we provide an intervention, it's not really one and done, that we have to sort of keep engaging with families and potentially re-invite them to participate again. These actually occurred in both clinical and community settings and utilized a variety of provider types, a huge range of provider types, and utilized group and individual sessions. So all of these sort of encompass what is a family healthy weight program. You guys today will hear about the program called MEND, or how it's sort of based on an original program called MEND, but there are other interventions that we can also talk about. Next slide, please. So which leads me to the CDC work. We recognized about 5 years ago that there were lots of barriers to participating in these interventions, right? Like we could talk about all of these barriers. It is not easy. But one thing that CDC felt was that, there's an opportunity to sort of package and make these interventions available. Next slide, please. So the CDC worked about 5 years ago to develop and put out an award, basically like a grant, called the Childhood Obesity Research Demonstration 3. This is the third iteration. And this award was actually geared towards packaging, adapting, testing, and implementing effective family healthy weight programs for children from low-income families. So imagine taking all those components, right? Somebody's been doing this work for 30 years in their little setting, let's say in the state of rural Nebraska, right? And then they take that intervention, they package it, put it on a website so that it can be used by other people around the country. So there are 5 awardees in our CORD program. Next slide, please. These are the 5 awardees on the left side. And the beauty of the CORD award is that by saying there need to be 5, 20, however many interventions, it says that not every child, every family needs the same thing from the intervention, right? And so this sort of recognizes the diversity of families, the diversity of living situations, the diversity of our needs for different types of interventions. And so CDC is packaging 5. They are all very different in their approaches, different in the utilization of staffing, different in where they occur, different in rural or metro areas, and different in their adaptability. Next slide, please. So we recognize one size does not fit all. We need a variety of options for the variety of resources that clinics have. We understand that adaptability is key for reaching diverse populations and for reaching equitable implementation. And so part of the award process has been really looking at and testing these adaptations and being able to test how, when you set it down in one setting, does that setting really pick it up? Next slide, please. So I just want to show real quick, this is sort of a grounded in theory method by which we use in the CORD award to make adaptations, right? So you can think about adaptations as opportunities for creating fit for a local site. And so this theory really shows you can make adaptations when you're implementing an evidence-based intervention. You just have to keep them grounded in the theory. And the core components at the bottom are those necessary things that make it work. We call that fidelity, holding to the fidelity of the intervention. But I really like using the word core components because that means we cannot change these things. We can make all of these other adaptations as necessary when we put it down and set it in our own setting. Next slide, please. Another way to look at this, which we sort of clung to in the COVID years, Jessica, others really sort of created and ran with this idea of what we call the stoplight approach for balancing fidelity or the core components with adaptability. And so you can think about like the red components of an intervention, we cannot change because that will actually change the effectiveness of the intervention. We can maybe modify or add components that might be necessary during a time. So we might need to add additional outcome measures. We might need to substitute an activity like a cooking class, or some folks invite all siblings to be involved. That does not change the effectiveness of the intervention. And then you can see the green adaptations we really see as an opportunity to increase the reach or to sort of reach populations that previously had not been reached by this this intervention that was developed for one specific population. So changing the language, the recipes, the time of the day, all of those things are adaptations that can be made. Next slide, please. So we really looked at a lot of this through an equity lens, and I say equity very specifically to talk about how we lifted certain populations that needed additional support. And so we can talk about it in with regards to individuals, and so that might be sort of needing a virtual model, language and culture, adapting for social determinants of health, or next slide. Where I see a lot of need is really around systems for equitable implementation. And so thinking about the data that we're collecting, making sure it's not a burden on the local system, but that it also can maybe identify disparities where we can act, right? Not just to track, but to act. Implementation in multiple settings. Some settings maybe have lower resources than other settings. And so how do you lift up one setting when that occurs? Making sure that recruitment is embedded in the package, that we really think about recruitment from the beginning. And then, as I talked about before, multiple, diverse, flexible interventions is important. Next slide, please. Here's my email address for anyone who wants to get in contact. Also, our website for the CORD project, and a link to a recent supplement that we put out on the CORD project, which really talks about how each of these interventions are being implemented in a real world setting. So with that, I think we'll hand it off to the next folks, and they can talk about what they actually did. I just talk about sort of the big picture. Thank you all.
No, thank you so much, Renee. We need the big picture. This is really, really great. Thank you so much for sharing kind of the landscape of you know, what all is going on. And now we will hear specific examples from who we fondly call our legacy teams. And legacy is health centers who've been working with us over multiple years in these projects. So let's go ahead to the next slide, please. Want to quickly introduce you to each of these legacy team ambassadors, as we're calling. So this afternoon, we'll hear from Chris Fields with Heal Mississippi, Kieske Bolton from GA Carmichael, Stina Doken from El Rio, and then Margarita Roman from BORINQUEN as well. So again, as we go along, please feel free to put questions or comments in the chat. If you have questions specifically for Renee or anything you heard right now, go ahead and you can start putting those in. Again, we'll have questions and answers at the end. But if there's other comments or anything like that, please make this chat nice and active for us. So next slide, I think we're going to start with Kieske, actually. Perfect. So I will give you the floor. Oh, I see you. Perfect. So go ahead, and when you want your slide advanced, just say next slide, and we'll get that for you.
Okay. I need to. I'm not sure why it's. I'm looking at you, which is a great picture, but I can't see my screen. So there we go. Yay. Okay. How you guys doing? My name is Kieske Bolton. I'm a registered dietitian, and I'm going to be speaking mostly on outreach, recruitment, implementation aspects of the MEN program or any program in relation to childhood weight management. If you have any questions specifically about our specific programs, I can answer that for you, but I'll be speaking mostly about the techniques that we've stumbled upon over this course of this 3 to 4 year period and how it's worked for us. So sometimes the biggest issue with childhood weight management in a community setting is just actually having children to provide the program to. And outreach and recruitment is vital to beginning a cohort. You want to try to have the largest cohort you can, because there's always going to be attrition for some reason or another. We all know the traditional methods, which would be referral, sometimes, just flyers or things like that. But a lot of times those things don't work so well, especially in this COVID and hopefully post-COVID time. So one of the things, if you're doing in a medical arena, is to consider a provider prescription. So A referral just means that you've had a talk with the doctor, and the doctor says, I'm going to refer you over to this, that, or the other, and then you get a call from that actual person. But what we thought about and have done in the past is actually having the provider write it out on a either prescription pad or a pad, where he writes it out and gives it to the parent, and the parent's job is to, quote unquote, fill the prescription, which is to actually join the program on their own accord without us having to contact them. A lot of times parents put a lot of stock into their providers' opinions, and when they receive a piece of paper from them saying, I want you to do this, they tend to enroll and remain in the program more so than if they just feel like they're sending them across the hall to talk to somebody. So you can also consider reaching out to staff for their participation. Sometimes staff members that work in a certain organization don't always see the providers in that organization, which means that their children may not see the providers. So a lot of times there's eligible kids right where you are, and you just kind of don't know where they are. So reaching out to staff members is kind of like a wonderful opportunity for staff to bring their kids to work, and for you to know that they'll probably have better attendance because they're already working there anyway. We found greatest success with combining our program in conjunction with pre-existing organizations, daycare centers, after-school programs, church organizations, and with us specifically here at GA Carmichael, we've had 2 full cohorts with the Boys and Girls Club. So sometimes if you don't have a strong pediatric presence inside your clinic, or if you're doing it and you don't have a clinic, contracting, having an MOA or MOU with the organization is best. You can go to the next slide. Once you've recruited, you gotta get them, and you gotta stay. You know, no matter how big that first group is and how excited you are on how many people showed up the first time, you want them to stay. Now, as my personal opinion, I think the men program in conjunction with the exercise portion is wonderful. It's one of the favorite programs I've ever done. It's super engaging, and if I had kids in it and I was on the other end, I would participate. However, we sometimes don't know what other things in their life or other activities are going to pull our people away. So outside of how wonderful the program is on its own, you want to make sure you plan your budget, your space, your staffing. You want to look like you got it together, because sometimes if you look like you're scrambling, they're thinking these people don't know what they're doing. So even if you don't, just wing it, but look like you got it together, and make sure that you form enough relationships with your participants so you know what will incentivize one, might not incentivize all. It could be money or prizes, but some people are just super competitive, and even though men is not based on competition, there's ways to make it competitive, even if just attendance. So some people love to meet in person. Some people really need that Zoom. So you really have to consider what's going to affect them. And also, we found great success with parents attending by letting the parents weigh in separately. We didn't really keep data on it, but the parents were so interested in whether they were losing weight or not as well. We just weighed them and wrote it down and threw it away. But it helped them to keep up with the program. You can go to the next slide. Oh, this is just some of the kids that we have this year. We have a really big cohort. These were the ones that volunteered to come up and take a picture. Go to the next slide. So some things to consider when you're implementing men specifically, or whatever program you're implementing, is this origin. For us, men came from the UK. A lot of the verbiage that we're delivering to participants is a little formal, like really formal. And we have to, obviously translate it's English from English to English, but we have to deliver the information to them in a way in which they understand. Doesn't mean dumbing down, but it just means we have to make sure that you're reading over your delivery prior to delivering it to the participants, because sometimes it's just not going to come out the right way, or you may sound a little hoity-toity. I don't know what other word they might describe that. We're in South Mississippi, Central Mississippi, so we've had parents who've had doctorate degrees all the way to parents who couldn't read very well. So we have to make sure that we're delivering it, and we need to familiarize ourselves with the text. Make sure that you stress to parents that it is a family program and that someone needs to be responsible. Otherwise, the goals that we set aren't going to really work too well. And without the exercise component, it can get really teachy and not fun. So make sure you have a really strong exercise component, which CATCH is the one that we use. You can go to the next slide. One of the things I had to learn by trial and error is that I am a facilitator. I am not a dietitian. When I step in front of that room, I am no longer the dietitian. I am the facilitator. And facilitation is a whole nother beast than nutrition education, teaching, being a provider. We have to be objective, focus on the group process, make sure that the group is working cohesively together to get to the goal of the program. And it can be difficult to be a contributor and a facilitator. You can't contribute your own thoughts, views, and also facilitate the curriculum. So you have to really familiarize yourself with the curriculum so you can be the curriculum and not necessarily your own thoughts and opinions. Definitely, if you are a provider or you have a provider that's going to be delivering the program, you stress that they don't step outside that role. That was one of the things that got me at the beginning, because I was facilitating to my own patients. Like, I knew them beforehand, and they would ask me all sorts of questions, and I would forget, okay, wait a minute, this is HIPAA, and so we have to be careful about that. Next slide. I think this is the last slide. More than anything, you really got to believe in the curriculum that you have, whether it's MEND or a different curriculum, because they can tell if you don't. If you're being a little flip about it, or you're not really enforcing the goals or the rules, then they won't take it seriously. If you believe in it, even if you have all sorts of trials and tribulations, it's going to work out because they're going to get something out of the program. Definitely don't underestimate how sophisticated some kids are, because socioeconomic status does play a role in some ways, but not all. Simultaneously, don't be surprised on how much someone doesn't know. So looks can be deceiving, socioeconomic status can be deceiving, educational status can as well. Ask the families to participate throughout the program for suggestions on making it better and more accessible, and then make sure you plan out time to prepare for class, because preparation is key. I think that's my last slide, but you can go to the next one just to be sure. Yep. All right, so if you guys have any questions, and let me see, are they in the chat? Okay, no questions. So you guys just let me know how I can help, and I'll be glad to.
Thank you so much. Excellent. Thanks for the great descriptions. Thanks for the pictures. Again, if anybody has questions, go ahead and plug them in the chat. We'll get to them at the end. We want to keep rolling, so we have time for everybody. So let's hear next from Heal, Mississippi. I think that's Chris.
Hey everyone, I'm Chris, and can you all hear me?
We can, go for it.
Okay, great. I am the executive director of Heal, Mississippi. And what I will speak to today is approach and implementation. I'll tell you a little bit about our organization. At Heal, Mississippi, we are a 501c3 nonprofit healthcare organization, and our mission is to reverse the advancement of cardiometabolic diseases in Mississippi, i.e. obesity, diabetes, hypertension, high cholesterol, and other diseases that lead to cardiovascular disease, heart attacks, strokes. Our vision is to establish a standard of care that combines all the necessary elements to address and reduce these risk factors and the risk factors of cardiometabolic diseases. Next slide, please. So we began implementing our vision by hosting and participating in health fairs throughout the state, providing glucose screenings, blood pressure checks, body composition analysis, nutritional screenings. And we did these in strategically selected areas in Mississippi. Through these efforts, we were able to raise awareness and disseminate information on the severity of cardiometabolic diseases, while also screening over 5,000 Mississippians. From there, we then leveraged our efforts and resources by establishing a lasting relationship with the Mississippi Primary Care Association. Initially, we partnered with them on their 65 by 65 obesity initiative. I'm not sure if you all are familiar with that, but it is an initiative to move 65,000 Mississippians out of obesity by the year 2065. It's a unique initiative. That partnership also allowed us to begin serving as their program coordinator for the MEN program, which is the childhood obesity program, as you all know, and have been told by CDC'S, which is being delivered in FQHCs throughout the state. Our main theme is basically establishing trust. What we did, we became a trusted community-based organization via our partnership with the PCA, which allowed us to implement and deliver other public health programs and these federally qualified health centers and their surrounding communities. Next slide, please. So from there, in April of 2021, we became a COVID-19 vaccination provider, administering COVID-19 vaccinations in communities throughout Mississippi, allowing us to transition from a community-based organization to a healthcare organization delivering clinical preventive care for these communities of needs and community organizations. So we have a somewhat of a unique design. We have a strong community element and base, and now we were able to deliver, we're actually able to deliver clinical preventive care to the communities we serve. Hosting these COVID-19 clinics throughout these communities also allowed us to strengthen our community partner map, enabling us to implement much needed health programs in these communities, like the MEN program and diabetes prevention program and other lifestyle-based programs. Next slide, please. So our structure is based on a community-based care model. The main theme of population health is preventive care. But as we know, like a mass of people won't just flood into medical or healthcare practice to partake in these prescribed health programs, which are designed to prevent the onset of diseases or that are designed to help manage chronic conditions and cardiometabolic diseases that are risk factors for stroke and heart disease. So emphasizing and utilizing community-based partners is in program design and implementation is necessary, we feel, especially for effective population health management, because what it does is it increases accessibility to these preventive care services, and it also meets the target population where they are in a comfortable setting. For ethnic groups that are disproportionately affected by these diseases, certain theories have caused a distrust and created a bias and stigma surrounding the healthcare system. So being able to establish community-based partners and effectively deliver these preventive care type public health programs can help, restore that trust so we can begin to see some changes and also see some relief in health disparities. So we were in a unique position. We started as a community partner, and then we kind of morphed into a healthcare organization with an emphasis on community partnerships. So through that, we began implementing the MEN program in churches and community organizations throughout Mississippi. As Kiski said, we utilized the Boys and Girls Club there. When we initially started implementing the MEN program, I think we've been doing it for 4 years now. The health centers we partnered with all took the approach of implementation in a clinical setting, which presented us with challenges from space to participation to manpower. So as we evolved and as we continued to implement the program, we realized that the best approach for these programs, particularly surrounding population health and preventive care, the best approach was utilizing community partners that actually had the capacity and also the manpower, like churches and Boys and Girls Club, to begin implementing these programs. That's all I got.
Perfect. Thank you so much, Chris. If anybody has questions around community partnerships or anything else that you discussed, please feel free to go ahead and put it in the chat or save it till the end to ask directly. Thank you for sharing, Chris. I really appreciate it. Next, we have BORINQUEN. I think, unfortunately, we do not have Margarita on the call today to share, but I believe Jessica has volunteered to talk through some of the slides. She's been working with them as an honorary BORINQUEN member, I think. So Jessica, if you don't mind walking through the slides, that would be great.
Hi,
there
guys.
You are.
I am so not Margarita, and for that I apologize. She's texting right now and having some technical difficulties. So I will speak on BORINQUEN's behalf as much as I possibly can, and we'll try and get you guys connected to her if you have any questions. But what's really cool about this is BORINQUEN had kind of similar issues that you've seen with Kiski and Chris and the 2 health centers in Mississippi, where it really is about taking that kind of packaged intervention and then making adaptations to make it their own. BORINQUEN is located in South Florida, just for reference. So, early on, even as they were kind of embracing the curriculum and really excited about it, they also felt that sense that the material was not kind of culturally the best fit for their patient population. They really wanted to add things like recipes, and how did they match the format with the fact that it was a clinical setting? What about community partners, and what about things like community health workers? Next slide. And so they really just kind of took ownership over making this work for the long haul. So adding in recipes, kind of having the staff and even families kind of review for cultural sensitivity points. BORINQUEN has done a lot of work around kind of integrating fully into the work of the health center. So their chief medical officer, Dr. Garcia, is very actively involved. Same with the pediatricians. They have pediatricians who participate in those MEND group visits, and kind of as they started building it out, they were thinking long-term about some reimbursement opportunities. They have a champion or ambassador providers that can help really spread the word and keep it on people's radar for those referrals. And, now as they're kind of continuing to build off of it, they have more of an integrative medicine approach. So really adding in behavioral health techniques and the wellness perspective, and more specialized wellness exercises, including yoga, which has been a big family favorite. Next slide, please. Okay, and of course, like everyone is mentioning, and that everyone has struggles with when you try to integrate these programs, how do you recruit enough families? How do you get the reach that you need to make it feel worthwhile? And so I think the BORINQUEN strategy has definitely been engaging those pediatric providers. They've also done cold calls back in the day, and just didn't really have a lot of yield for getting families to join. So when they could do things like warm handoffs across those pediatric locations, I found that to be really helpful. They now have an internal EMR-based referral process as well for when you can't do the warm handoff. And now they're kind of honing in more and more on who are the right families, and how do you kind of ask the questions, that little motivational interviewing, are they ready for this kind of intense intervention? And, making sure that those are the families that you reach, and which communication styles work best over time, really just continuing to cater to what their patients and their families need. And I think another piece that they've been building out over time is, using the curriculum, using the adaptation, and then getting that leadership buy-in. That means their executives, it means their board members, number one, showing how important and needed this kind of intervention is, to her point that children are in a very dangerous and preventable state. And then using the feedback from the intervention, right? How effective is it? How are these kids doing over time? Then the provider billing piece, which is, the love language of a lot of our health centers, really paved the way for that executive and board response and support to integrate it and kind of continue to allow it to continue.
I think that's it.
That's it.
We're going to move to El Rio last. Thank you, Jessica, for standing in for Margarita. We will put Margarita's email address in the chat. So if anybody wants to follow up, we would, totally welcome that. And I see there's some questions coming in, so keep them. We only have to hold them just for a few more minutes. We want to let Stina from El Rio share next, and then we'll have a great time of discussion and questions at that time. So Stina, if you want to go ahead and start sharing about your work at El Rio.
Yeah, absolutely. Thank you so much. So I'm relatively new to this role, but El Rio has been participating in this MAC cohort for this year 4. So we at El Rio recently got a new electronic medical record system in November. And so that was a bit of a challenge for us in our referral process for MEND, because the referrals that we had in our old system weren't accessible anymore. So we kind of had to start from scratch. But in my role, we, presented to a lot of different departments within El Rio, the pediatricians and family medicine, behavioral health, and just kind of got the word out that way. And also we went like the journal flyer route and tried to just get the word out amongst staff. And so we did accept referrals for kiddos for the program through our EMR, and were eventually able to access those. So we got a lot of good referrals from family medicine and behavioral health mostly. And then we ended up opening our program up to staff and their families as well. So we ended up getting a few staff members just emailing me directly that they wanted to join. And so we kind of got about 50-50 through referrals and 50% through staff members and their families. So yeah, we ended up with quite a few referrals, 70 within 5 weeks, the first 5 weeks of having our new EMR system, and their new ones are coming in all the time. Next slide, please. So we started our program based off a centering model where all of the families came to our kind of jumpstart event and received a 10 to 15 minute visit with Dr. Mockbee. And, I think that was really eye-opening for a lot of us and for our Dr. Mockbee as well, to kind of see what the families were struggling with and maybe how severe their needs were. Because maybe these were some of the families that weren't regularly making it into our health centers or hadn't been in a while. And we're looking for a different approach or something that met their needs in a different way. So that was really informative to all of our staff. And we are offering referrals to behavioral health consultants and our registered dietitians at every meeting. And we're kind of keeping track of how many of those appointments have been followed up on and recurring. So that's given us some good data. Next slide, please. Our program is currently running completely virtually via Zoom. We do have a couple optional in-person events. We did a hike in Tucson up to Mamak Hill. We're doing a grocery store tour and in-person cooking class. But right now it's mostly Tuesdays and Thursday evenings via Zoom. So we have instruction on Tuesdays and family-friendly cooking demos on Thursdays. So we've been making some really good recipes. We had a cauliflower curry and sweet potato tacos. Last week we made overnight oats with berries. So it's been fun getting to do those things with kids. And all of our sessions are led either by myself, by behavioral health consultants, registered dietitians, and we've also had one of our El Rio yoga instructors lead some family-friendly yoga sessions in our Tuesday night sessions. One thing that I did to kind of work through the engagement issues and retention was I created, excuse me, a website that houses all the slide decks from our presentations, as well as all the recipes that we use on Thursday nights, and just some additional resources for mindfulness and Tucson local family resources. So like how to access our Tucson Community Food Bank, what other kind of resources are there through El Rio or the community. They're all available on that one website. I think that might be it, but if that's another slide, really I kept it short and sweet. Oh yeah, there's some screenshots of the website that I created for our families. And it does have the Zoom link to the session right on the homepage. So parents don't have to go searching through their emails to get it. They can just click on the website and find it right there.
Excellent. I think you have one more slide, one more picture
Okay.
in there too, maybe. Oh no, that's my slide. Thank you, Stina. Thank you so much. If we want to give a virtual clap to all our presenters today. Excellent, excellent. Thank you so much. I think we learned really, 4 different ways of doing 4 different things. And so absolutely want to open it up to questions now. We actually have a couple already. I would like to say, if you saw in the chat, Margarita made it in. So if you have questions directly for BORINQUEN as well, Margarita's back.
Sarah, I'm going to go ahead and take us out of the screen share just so
perfect.
we're in
Thank you.
a little. I
In
can share it
gallery.
again in a little
I
while.
love
Yep,
it.
in
Nope.
gallery. Let's see everybody. Yeah, awesome.
Thank you. Perfect. So we'll take the questions in the chat first, and then after that, if there's any the burning questions, feel free to raise your hand, or we'll figure that out. So first question is for Chris with HEAL. What was your biggest barrier, and how were you able to overcome it? That was from Walter.
I think our biggest barrier was recruitment and retention. And actually, believe it or not, COVID-19 kind of helped us overcome that, because what it did, it forced us to be innovative in our delivery, because initially it was in person. So what we did was we kind of transitioned to a hybrid model, a virtual / in-person model for delivery. So we made it convenient for the parents to be able to attend with the virtual, and also we, kept to the, kept to the design of the MEN program, and was able to deliver the program in person for the children. One way what we did through the pandemic was we utilized the community health workers or the community health worker model for recruitment for our hard to reach in rural areas, because they kind of knew the lay of the land, and they were actually familiar with the community and how to reach them and how to service them. Excellent.
Thank you. Next question is how, and this is for anybody, so you all can take turns or take the question. How are centers sustaining these programs or programs like this after grant funding goes away? Any answers to that? Maggie, do you want to take that first, since you just joined us?
Yes, I would love you. Yeah, love to.
Thanks.
Thank you so much for your patience. I apologize. I don't know what was going on with my link. It wasn't working, and I hadn't noticed the time. So anyway, I apologize, but thank you for reading my slides. It definitely is a good way to, it's an important thing to tap into the reimbursement possibilities. From what you guys saw in the presentation, we're able to bill for our pediatrician or our PA. That part actually wasn't really in the slides, but we're able to reimburse for our PA. We're not able to reimburse for our nutritionist, but any opportunity that you may have for reimbursement at any time, even if it's the smallest amount, it helps to start showing our C-suites, our senior executives, that there is a possibility and a potential to continue making money from this. So that helps the sustainability, and also just making it as much part of the workflow where it's hardwired into the process of the entire organization. If every provider and every staff member knows that this is just something that your organization does, it helps that helps. It's a high amount of much more buy-in when it just becomes a regular process of everyday life. So yeah, hardwiring and find ways to get that reimbursement. Those are my two top things.
This is Kiski. I have a comment on that as well.
Go for it.
I agree with everything that you just said. One of the things that we have not done, will do if the funding decreases or goes away is, well, one of the things that we do now is we create an encounter for every participant when they attend class. So although the encounter is considered other professional services or in-kind services, it does go toward us as a community health center, the number of encounters that the facility has for the year. Also, it's shown under me as a provider. Now, I am a provider and I do can bill for services. So depending on whether you're with a nutritionist or a registered dietitian, the billing may be different. Another thing that you can do is actually, and I do a lot of advocacy on another side, community-wise, is that make sure that you support advocacy efforts for reimbursement for other professionals outside of the doctor, nurse practitioner spectrum. And lastly is what we will do if we don't have any funding at all is make sure that we have a provider who may be a LPC or LCSW or doctor or nurse practitioner come in and have a small visit with each participant while the program is going on. So since it's 2 hours, they can spend 10 minutes or 15 minutes with each one, maybe not every week, but once a week, so that it can be billed for a wellness visit or a check-in or something like that. Also, community health workers are getting more reimbursement lately. So we may implement another component where they may meet with someone, and then whenever there's something that can be billed as a group, we'll try doing that as well. But I mostly agree and love what you said about making it a part of the program, a part of your services, because once people get used to having it and once employees get used to it, they'll usually find a way to make sure that people are paid, and also utilizing staff that may work with other grant programs throughout, so that even though they may only spend 3 or 4 or 5 hours a week on the program, their salaries are covered in a different way.
Excellent. Thank you for sharing. Sina put in the chat, at El Rio, all the resources we provide in this program are already part of our wellness department. So the things we provide through our program will continue to be provided with or without grant funding. So kind of, as each of you have said, kind of like make it part of what you do. Awesome. Sina, if you have anything else to add, feel free, or anything else to add to that question, Chris? Maybe not. Okay. Other question that came in, were these programs only open to the health center's patients? So if you all want to each answer that.
Well, this is Kiski. The answer is technically no. They may not start out being a patient, but once we capture them, they are added to our EHR system and treated as a patient, even though they may have not stepped into the building. So they don't have to start out a patient, but in order to capture their data and have a place to record it and create encounters, then they do become quasi patients.
Margarita, how about your site?
Yep, I second that completely. That's the perfect answer. Yeah, that we do the same. And those circumstances have come up usually when we have a family that has siblings that might have been a little too young for the program, or maybe that we didn't know about because they were non-active patients of BORINQUEN. And once we start seeing them on camera, we work with the parents to register them into the system so that we can count them. Absolutely. That's the lovely part of having everybody registered and creating an encounter at the EHR system. So tracking.
Excellent. Any other answers from Chris or Stina? Okay, we have another question that just came in. Thanks, Jane. If they become quasi patients, can you get reimbursed if they don't have a referral from their PCP? Thoughts?
That's a good question. I'm not sure of that. I feel like once they start seeing it, so let me back up. Most of our patients are like Medicaid patients, and so they're pretty free to go out to have any provider that they want to have. They're not locked into any kind of HMO Medicaid. At least in the state of Florida, most of our kids have straight Medicaid. So once they start seeing the pediatrician that's part of the provider of our program, we're able to bill with that, even though that was not the original assigned provider, because there's no such thing as assigned provider in Medicaid, straight Medicaid.
Perfect. Jessica's put in the chat about Denver Health. This is not specialty care, but part of primary care. So no referrals needed. Excellent. Thanks for sharing that, Jessica. Anybody else want to share about the referral barrier, or maybe not barrier?
Sarah, can I add something? Since
Please.
we're talking about siblings.
Yep.
I wonder about, the opportunity I put in here, caregivers. What we find is that insurance really cares. Caregivers can be costly, right? Like if you already have diabetes or you already have the comorbidities. So I wonder about, has anyone identified opportunities to link parents in, sort of like, oh, well, you're mentioning this. Have you already participated at our health center, or, opportunities to sort of bring them in? We have DTP or other programs for families.
That is a very great thought, and we have tried, and actually our last meeting before this come to the table meeting, we had discussed that a little bit. BORINQUEN has been trying in the last year to better engage the parents, and we did do a check to see how many of the parents that were sending us their children. Well, they have to all participate together, but how many of the parents were actually also patients of ours? And we were a little discouraged to find that none of them were, maybe one or two. We did try to provide some education to get them to start having services with us so that there would be billing opportunities in the future. That part, we have not succeeded yet. I think that we need to rethink our approach, but that's definitely on the plan. That's definitely one of our long-term goals.
I'd love to continue that conversation, Margarita. It's really, it's so important. So I'm super excited you've already engaged. I'd love to hear about this.
One of the things that we do with the organizations that we work with, we do have the National Diabetes Prevention Program in the churches. So we kind of use the family. So we take the caregiver through the National Diabetes Prevention Program, and kind of a mesh between the two, the diabetes prevention program and the MEN program. So it kind of turns it into, or morphs it into a family program or a family health program.
I love that. Thank you, Chris, for sharing.
Excellent. Well, I hate to end this party. I feel like we're just getting started with great questions and answers. Jenny, I see your question. We'll make sure we get that to the presenters, but just want to give a couple reminders. It's so sad to say, but this was our 5th of 5 modules. Come to the table modules have gone, the whole learning series has gone really, really quickly. I do want to share just a couple kind of closing announcements. So first and foremost, when you leave this particular learning series, you will get a link to fill out a survey. For those of you who are able to get CME, there is a CMA link to that. So we would love for you to fill out that survey. But even if it's not linked to CME from you, we would still love to hear from you. This was a learning series that we hope will continue on, and we will offer again, and perhaps some state programs and other areas will be able to also offer something like this as well. So definitely your feedback is really, really, really coveted by our team. We will also be sharing the recordings. I see there's one question if they can be reviewed indefinitely. We will make sure they're as accessible as possible for as long as possible. And again, we may iterate on this and offer this again. So definitely tell your friends about it. We'll be reaching out to those of you who have attended to be able to then share, future learnings for that as well. We are going to have a dessert round. Again, this was a feast. Come to the table. We have so many great speakers that each of you really wanted to hear more from. So we're going to be setting up at least one, if not more, dessert rounds where it's more informal. It's almost like an office hours or a coaching or a, sit at the table and have a chat. So we'll be announcing those dates out soon as well. And again, we'll be sharing this recording with each of you who have attended. We'll be emailing that out. Thank you so much. I want to especially thank the NAC team, both Jenny, who built the majority of the content through this learning series, as well as Jessica, who both of them spent countless hours putting this together. Naomi behind the scenes, also putting this together and make sure we're all organized behind the scenes. And of course, Liz for hosting and making sure this actually happens live via Zoom. Thanks to to Renee and Ali and our CDC partners for sponsoring this and helping us think through how this would be meaningful, but especially to all those who have attended, whether it was one